You got the test. The result came back normal. Your doctor said the thyroid is fine. And yet, you are exhausted. Gaining weight despite eating carefully, hair thinning, cold when no one else is cold, brain running through fog. You've mentioned it at appointments. You have been handed reassurance instead of answers. You are not imagining it, and the test did not catch it. Here is why. The standard thyroid test measures one thing, TSH, thyroid stimulating hormone. And here is the first thing most people are never told. TSH is not a thyroid hormone. It is produced by the pituitary gland in the brain. It is the signal the brain sends to the thyroid asking for more hormone. Testing TSH is like checking whether your boss sent an email, not whether the work actually got done. When the thyroid is producing too little hormone, the pituitary notices and raises TSH. That's the case the test was designed to catch. But that is only one way the thyroid system can fail, and it is not the most common one. The thyroid produces T4, a storage hormone that is almost entirely inactive on its own. For it to do anything, the body must convert T4 into T3, the active form that enters your cells and drives metabolism, body temperature, mood, cognition, and energy production. This conversion happens in the liver, kidneys, and gut, not in the thyroid, which means you can have a thyroid working perfectly, a TSH that looks completely normal, and still be profoundly hypothyroid because the conversion is failing. Chronic stress impairs it. Cortisol directly suppresses the enzyme that converts T4 to T3. Selenium deficiency impairs it. Selenium is a required cofactor for the conversion enzymes, and most people with thyroid symptoms are low in it. Chronic inflammation, iron deficiency, liver dysfunction, and caloric restriction all shift the pathway away from active T3. A 2018 review in Frontiers in Endocrinology found that up to 20% of patients on standard thyroid medication, T4 only, still report significant symptoms because their T3 conversion remains impaired. TSH normal, T3 low. The test says fine, the body says otherwise. And it gets more complicated. The body can produce a molecule that looks exactly like T3, fits into the same cellular receptors, and does absolutely nothing except block the real T3 from getting in. It is called reverse T3. It is produced when the liver converts T4 down the wrong pathway, a pathway the body preferentially uses under stress, severe illness, after surgery, or during prolonged caloric restriction. Reverse T3 occupies the receptor like a key that fits the lock but will not turn. Active T3 cannot get in. The metabolism slows, temperature drops, weight increases despite restriction, brain fog deepens. The patient's TSH looks normal, free T4 looks normal, even free T3 can appear borderline acceptable. But reverse T3 is filling the receptors and blocking the signal entirely. Every symptom of hypothyroidism in a patient whose standard panel shows nothing actionable. Most doctors do not test for it. Most patients do not know it exists. And without knowing it exists, there is no reason to ask for it, which is exactly how it stays hidden for years. Now add Hashimoto's thyroiditis, the most common autoimmune disease in the world and the leading cause of hypothyroidism in developed countries. In Hashimoto's, the immune system produces antibodies that attack the thyroid directly. It is a slow destruction, and in the early to middle stages, the remaining thyroid tissue still produces enough hormone to keep TSH in the normal range. The test looks fine. The immune attack is already underway. In fact, during early Hashimoto's, as thyroid cells are destroyed, they release stored hormone into the bloodstream. This temporarily causes hyperthyroid symptoms, anxiety, racing heart, insomnia, weight loss, before the damage becomes extensive enough to produce hypothyroid symptoms. The patient swings between feeling wired and feeling exhausted. This is frequently misdiagnosed as anxiety disorder, perimenopause, or stress. The antibodies that confirm Hashimoto's, anti-TPO and anti-thyroglobulin, are not included in a standard thyroid panel. TSH does not detect them. A patient can have confirmed autoimmune thyroid destruction with a TSH of 2.1, solidly within range, completely invisible on standard testing. The disease can progress for a decade before TSH shifts enough to raise a flag. And then there is the range itself. The reference range most labs use to define normal TSH is 0.4 to 4.5. But that range was calculated from a population that included people with undiagnosed thyroid disease, because thyroid disease is so prevalent that any large population sample contains significant numbers of people with subclinical dysfunction. Their values pulled the upper boundary upward. The range is contaminated by the very disease it is trying to detect. In 2003, the American Association of Clinical Endocrinologists recommended narrowing the normal range to 0.3 to 3.0, arguing that values between 3.0 and 4.5 represent subclinical hypothyroidism in symptomatic patients. That recommendation was never universally adopted. Most labs still use the broader range. A patient with a TSH of 3.8 will be told their result is normal. By a separate but scientifically supported standard, it is not. And if that patient is symptomatic, young, and otherwise healthy, the difference between those two interpretations is the difference between years of unanswered symptoms and a treatment that actually works. So what does this mean for you practically? A complete thyroid evaluation includes free T3, free T4, reverse T3, anti-TPO antibodies, and anti-thyroglobulin antibodies, not just TSH. Free T3 below 3.0 picograms per milliliter in a symptomatic patient is clinically significant regardless of TSH. A reverse T3 above 15 nanograms per deciliter competing with a low normal free T3 suggests receptor blockade. Positive antibodies with a normal TSH confirm Hashimoto's in its early destructive phase. Supporting markers matter too. Ferritin below 70 nanograms per milliliter impairs T4 to T3 conversion. Selenium below optimal range impairs the same enzymes. Vitamin D below 40 nanograms per milliliter is associated with higher antibody levels and poorer treatment response. These are not exotic tests. They are the tests that map the full production chain from pituitary signal to cellular